Welcome to this episode of Knowing Your Way, a Princess Margaret podcast on ovarian cancer. My name is Alicia Sarabia. I've been living with ovarian cancer for over 6 years now. I'm married, I have 2 adult children, and I'm a physician, although not a cancer specialist. This podcast is a resource for all people affected by ovarian cancer, whether they are patients living with ovarian cancer or if they are family or friends of a patient with ovarian cancer. The Princess Margaret Gynecology program and I want to assure you that you are not alone. We see this podcast as a way of helping you gain knowledge and inspiration along your journey. We hope that you enjoy this podcast. This particular topic is on exercise and ovarian cancer. It's called Small Steps, Big Gains, Optimizing Health Through Exercise. Prior to reading up on this topic of exercise oncology, I was completely unaware of the vast amounts of research that has been done in this area. And I was very happy to make contact with 2 experts in this field, Drs. Daniel Santamina and Dr. Sarah Ferguson. I'll introduce you now. Dr. Santamina is an associate professor with the Department of Kinesiology at the University of Toronto, and he has a special interest in exercise oncology. And Dr. Sarah Ferguson is someone that some listeners may already know from the ovarian cancer clinic, and I think the gynae oncology clinic generally, as she deals with more cancers than just ovarian. Dr. Ferguson is a professor at the Department of Obstetrics and Gynecology at the University of Toronto, and she's the Director of Research for the Division of Gynecologic Oncology at University Health Network. Thank you, both of you, for agreeing to participate in this podcast.
Great to be here, Alicia.
Nice to be here.
So I'm just going to start off talking about my personal experience as it relates to exercise and ovarian cancer. And then after we've completed that phase of the podcast, I'll turn it over more to Drs. Santamina and Dr. Ferguson so that they can provide us with some input as well. Prior to being diagnosed with ovarian cancer in December of 2015, I would say that I was fairly physically active. By no means was I an athlete, but I did my hiking. I would work out at the gym. I played tennis very poorly, but nonetheless, I tried to keep active. It was a good way for me to stay in shape, to clear my mind after a long day at work. Sometimes it was just a nice way to be social with my friends and with my family. So I underwent surgery shortly after the diagnosis of ovarian cancer was made. And after a few weeks, when my doctor, Dr. Bernardini, felt that I was ready, I began chemotherapy. And this took about 4 months to complete. I must say that the surgery was very difficult for me. It was a very challenging time in my life for a number of different reasons. But one of the reasons is because the surgery itself really zapped me of energy, stamina, mobility, and strength. And I was kind of taken aback at how debilitated, how frail and dependent on my family and friends I would be during that period. So that was difficult for me to experience. After a while, though, gradually I became stronger and I was receiving chemotherapy, and I started challenging myself to small, short sessions of exercise. Initially, that consisted of online exercise. So, for example, I found some yoga programs online on YouTube. In fact, there's a great program that many people know about called Yoga with Adriene, and another program called Eccentrics, like very gentle, but very comprehensive forms of exercise that were good for me physically and mentally. And then the weather got better. It was springtime. I was able to go out for progressively longer walks with family and friends. And as summer rolled along, I found that I could go hiking in the woods, which was really an enjoyable experience for me to be outside in nature finally, after having been cooped up inside for a long period of time. And I did some swimming and some biking and found that my level of energy, strength, mobilities, they all increased, which was very good for me. So that continued for a period of time. In October of 2017, I became aware that the ovarian cancer had recurred. And I went through the chemotherapy, but going through it the second time, I knew that although I might have been feeling fairly weak around the time of the chemo sessions, that I could manage it, that I could gradually get my strength back. And so the shock of it was not as it was during the first episode. And after the chemotherapy had been completed, I went on to another form of chemotherapy, quite different. It's called olaparib. It's a medication that I take by mouth on a daily basis. And it is associated with tiredness, fatigue. But I have been trying to listen to my body more while on this drug. And I know that in my case, if I exercise during the morning and get my tasks done during the morning, and if I rest in the afternoon, that I can manage this side effect of this drug. And so I think if I were to provide you with advice, which is what I'm doing by way of this podcast, I would say that it's important to be patient with yourself as you go through this journey, and to know that small steps are what is needed at the very beginning as you start to try to recover from surgery, from chemotherapy, the side effects of the chemotherapy. And you will, in fact, see that big progress can be made. And that also, if you take charge of some form of an exercise routine, that it will be a way for you to empower yourself. So you'll have your physicians and your oncology team in clinic looking at numbers, your lab test result. They'll be making assessments when you go in for your clinical visits, but you can also monitor how you're doing yourself as you become stronger and develop more stamina with time. So it's a way, again, of empowering yourself. And I think that's really important for those people that are affected by ovarian cancer. So at this point, I'd like to turn over to our guest experts, Dr. Mina. Perhaps you could begin with sharing with us your observations and conclusions that you've made over the course of your career, and from the knowledge that you've gained in keeping abreast with the literature that is there, that would be of great value, I think, to our listeners.
Sure. Thank you so much, Alicia, for sharing your story and creating this podcast. I think that many of your listeners and viewers will appreciate everything that you're bringing to the table to support their journey. Yes, in terms of exercise oncology literature, it has grown rapidly over the last several decades, probably with the earliest research starting in the mid-1980s, looking at the effects of physical activity and exercise for women with breast cancer. But especially in the early 2000s, there was an explosion of literature that examined the effects of exercise across all cancers. And it continues to grow. In fact, probably one of the most recent systematic reviews probably pegged the total volume of literature, and specific to randomized controlled trials, at about 2,500 to 3,000. So there is a solid evidence base describing the various benefits and effects of exercise for people with cancer. When we look at the entire spectrum of the disease, there are data to support the prevention of many cancers, probably up towards about 30% for those who are most physically active to those who are the least active across a number of different cancers. And then if you look across into the pre-treatment space, prehabilitation is an area that I'm really interested in, and its effects on the surgical experience and its recovery. And then we move through the data towards the during treatment and post-treatment outcomes, which probably is the strongest data to suggest the benefits of exercise in terms of mitigating many of the things that you described as very problematic in your recovery, whether it's quality of life, physical function, your social interactions, and your capacity to do the things that you love doing and that make you, you. And then if we move a little further down the continuum of care, we see that exercise actually shows a protective effect against mortality and it increases survival. And there's a strong evidence base to support that as well across a number of different cancers. Some cancers, there's more data than others. In fact, ovarian cancer probably is unfortunately one of the areas that is least well known when it comes to exercise and its various benefits, but it's not something that is completely undiscussed or undescribed or unassessed. There is just a smaller evidence base in the ovarian cancer world than there is, for example, in colorectal, breast, and prostate, where it seems to be, probably the most evidence there. But when you look across the board, exercise provides benefits, including those for people who are undergoing chemotherapy, surgery, radiation therapy, immunologic therapies. So, I mean, just to summarize very quickly, there is a ton of evidence to support the inclusion of exercise as a standard component of supportive care within the oncologic space. And it's been very exciting to watch the evidence grow over my career.
Mm-hmm. So to break down what you've been sharing with us, Daniel, generally speaking, the research has supported that exercise can prevent certain types of cancer. We don't know that about ovarian cancer, but generally this may be true. Is that correct?
The prevention outright is probably a bit of a stretch in the data, but there's upwards of about 30% risk reduction for a variety of cancers. And for some cancers, there's stronger data than in others. In the ovarian cancer space specifically, recent systematic reviews have probably topped at around 20% risk reduction. And that evidence quality is modest to moderate. So it's not terrible data, but it's not necessarily quite as strong as it is for prostate or breast or colorectal cancer, where the data suggests that there's upwards of about a 30% reduction in cancer incidence, and that data is stronger by methodologic criteria.
Okay. And then you touched on the importance of what is called prehabilitation, which is, I guess, optimizing physical, probably mental health prior to surgery, which in the setting of ovarian cancer may be difficult. I would imagine, for example, I had a 2-week period or 3-week period between time of diagnosis or assessment at the clinic and the surgery. And I imagine that would be very similar to many women that present to clinic. Dr. Ferguson, in our preparatory meeting, you were speaking about the fact that many women have to go quickly to surgery and how busy a time that is, and that it may be difficult to get yourself in optimal health at that time, that short period of time. Whereas in another group of patients that may have chemo before surgery, they may be able to benefit from looking at these lifestyle changes. Is that correct?
Yeah, thank you. I think that with the majority of women who present, let's assume with the presentation of advanced ovarian cancer, often women are very symptomatic and, first of all, unwell. So their functional status has often changed really, really rapidly over like 4 to 6 weeks. And when they present, whether we decide to start with surgery or chemotherapy, they are in a situation where they're not well enough necessarily to start, a formal exercise program. And with regards to those who we think are a candidate for primary surgery, it's usually because they're very symptomatic, often with fluid and either around their lungs or their belly, and pain and fatigue, often significant fatigue, we try to get them into surgery before we lose that window, before things progress. If we feel they're not a candidate for surgery first, but chemotherapy first, I think that there's more of an opportunity because we usually get 3 to 4 cycles, and usually women get much better quite quickly with chemotherapy. It's always hard for them to believe that they're going to feel better once the fluid dries up, and then there's probably a really good opportunity to increase their capacity for exercise and mobility and in preparation for surgery.
Okay.
Yeah, if I may just jump on to that concept quickly here, a recent study out of the Mayo Clinic by Clarissa Poland, they talked to women with ovarian cancer, advanced ovarian cancer, who needed neoadjuvant chemotherapy. And one of the themes that they discussed in that particular study was the opportunity of trying to prehabilitate during the course of neoadjuvant chemo, with the idea of maintaining their function as long as they could, perhaps increasing it so that they'd be a little bit more resilient for the surgery thereafter. So there is definitely some qualitative data supporting the interest and willingness to participate in a prehab intervention throughout neoadjuvant therapies.
Okay, great. So just for our listeners, Sarah, Dr. Ferguson, can you inform them of what is meant by neoadjuvant therapy?
Yeah, so neoadjuvant chemotherapy is when you're giving some type of treatment, usually chemotherapy, so medication you get through the IV before a planned surgery. So with ovarian cancer, there's multiple reasons why your doctor does or does not choose chemotherapy first. And one of them is that women, functional status changes very quickly with the presentation of ovarian cancer, which is not really typical of a lot of cancers. So women with breast cancer, I'm not saying that women can't present very unwell, but the majority are picked up with screening or palpation, and they're fairly well, and it hasn't affected their overall ability to perform everyday activities. But often when women who are very independent, maybe very active, all of a sudden they're, very short of breath and fatigued. And that on itself can be a limitation to doing surgery because of the huge impact surgery has on people with regards to healing and fatigue. I think that you really described really well, Alicia, and I think as surgeons, we're really bad at letting patients know that surgery, even if you start at a high functional state, is extraordinarily fatiguing, if that's really a word, fatiguing, because there's a huge amount of energy that goes into healing, and we're really underestimate that impact. Even if you have a course that there's no complications, even if you started really with a very well, it can really be a huge impact. And then you have women who present unwell who go to surgery, and it's even really, the biggest part, I think, is those primary surgeries are very hard on women. The neoadjuvant chemotherapy given before surgery, it's every 3 weeks, and people get 3 to 5 cycles. So there is months where, probably initially they can't start a program, but could work up to it, to something. And I think Daniel's probably going to talk about this idea. I think in our society, we always think exercise is this really regimented, tough, we're all working, Instagram life, where when we talk about exercise, it may be being able to balance on one leg so you can get up from a chair, to those who are much more fit, I don't know, running or doing something more intense. But for us, it's the small steps with big gains. Because as you described very, very eloquently, being in bed, recovering from surgery, we decondition so rapidly.
Absolutely.
Like shockingly. And our muscle mass, you see people who are, Dr. Santamina can talk about this, but we look at patients and they may be thin, and you always think, oh, they're so healthy because they're thin, but what is their muscle mass and how much resilience do they have? And how much surgical frailty do they have based on their muscle mass? Anyways, I'm kind of going off on a tangent, but neoadjuvant chemotherapy is the treatment of chemo before planned surgery. And probably half of women with advanced ovarian cancer, so women who present with disease outside their ovary, will receive chemotherapy first based on the disease distribution and not being able to surgically remove it. And the other big one is on their functional status, so how well they are to tolerate surgery.
Okay, thank you. So again, we were saying that there's a potential window there for women to start thinking about improving their physical abilities versus the women that need surgery very quickly. Often there's no time. And then I guess Dr. Santamino was also referring to that phase that occurs after the surgery, perhaps after the acute chemos, if you want to call it that, have been received by the patient, that there's also a fair amount of data to suggest that there is, generally speaking, at least, an improvement in various measures, including quality of life. I think I heard the word mortality. And again, remembering that many of our listeners are lay people, if we could define some of the words that we're using in order to help them understand better the benefits of exercise.
Sure. When we're thinking about the benefits of exercise and where this all started, it really did start as a rehabilitative or supportive care strategy to ensure that the problematic symptoms of cancer and its treatment could be resolved in ways that didn't require more drugs or more intensive treatments. And I think when we think about the value of exercise and perhaps the most common adverse effect associated with cancer treatments is fatigue. And that's really where this all started. Could exercise, in fact, reverse that unfortunate cycle of fatigue where someone is feeling tired because of their chemotherapy? They end up doing less, but in doing less, their sedentariness or their lack of activity creates a deconditioning, which means that their body is less able to do more things or anything at all. And then they become more fatigued when they do anything at all. And then they stop doing stuff, so they become even further deconditioned. And you could see how this downward spiral becomes, a path towards dependence rather than independence. And so the idea behind exercise is to try to break that cycle up. Could you, while feeling fatigue or while at high risk of fatigue, exercise in ways that conditions your body to be more resilient, as Dr. Ferguson mentioned, to the tasks of daily life, or in fact to the tasks of to the demands of additional treatments. And this idea of building resilience against fatigue with exercise is something that's been a primary focus of the evidence base for a long time. And fatigue is multifaceted. It's psychological, it's physical, i.e. functional, and it's also physiological. And one of the great things about exercise is it's also multidimensional in the way it helps people. You talked about being outside in nature and going for walks. Well, that invigorates you, it makes you feel good, it inspires you to do it again, even on days when you're not feeling so good, because it gives you the endorphins that support a positive feeling. When it comes to being functional, you need to have a muscle mass to be able to carry out the various activities of the day. And we're not necessarily just talking about, as Dr. Ferguson said, going to the gym and sweating away on the treadmill or throwing big weights around. We could simply be talking about getting out of bed, going up the stairs, taking the dog for a walk, playing with grandchildren. These are things that mean a lot to quality of life that people don't necessarily associate as exercise-related outcomes. These are just outcomes that keep us doing what we do. And then, if we go just a little further down, we talk about the effects at the muscular level or at the biological level that just support our function and support our survival. And so to define mortality, it's the unfortunate circumstance of succumbing to the disease or dying. And the idea behind a lot of the research is says that, therapies are great, but if they're not extending survival, are they really what we should be focusing on as much? And so a lot of the literature that has driven the importance of exercise oncology really has been in the area of mortality. And such epidemiologic studies with 40,000 patients of mixed different types of tumors has shown an upward a survival benefit of about 40%. And it's not necessarily just cancer-specific survival, but also all-cause survival. And I think what's relevant about that all-cause survival or surviving despite the health challenges that you may face is that chemotherapy is very cardiotoxic. And many of them are, I should say, at least. And what I mean by cardiotoxic is that they affect your heart and the vasculature in ways that actually put you at risk of cardiovascular disease. And exercise is a known intervention to support heart and lung health and vascular health. So it's not necessarily just specifically the cancer outcomes, i.e. what happens at the tumor level, although there's great biological data to support that exercise suppresses some of the tumor driving functions. But it's really at the system level, the whole body level, the quality of life level that exercise has really had a strong effect.
Okay. And Dr. Ferguson, this might be a good time for us to talk about the chemotherapy that is used in patients with ovarian cancer and how they may or may not affect various organs.
Yeah, so that's a good point. And I think, one thing about cancer, because lots of people will get anecdotes from friends and family about other people's treatment, is that chemotherapy is very cancer type specific. And so extrapolating from your friend or family member who has had treatment for breast cancer isn't the same as ovarian. So the fears, it's good to talk to your doctor about the fears about any of the medications, because people will tell you, people like to share, and sometimes it's scary. So with regards to the medications we give for ovarian cancer, fortunately, they are not, unlike with a lot of the medications for breast cancer, that cardiotoxic, or really most of them are not cardiotoxic. There's a few we use in situations of recurrence that over time can have effects on the heart. And that's really important to know. But there are other, we generally I'll use the drugs, and many people, your listeners will know them, but carboplatin, or a platinum-based drug, or Taxol or paclitaxel. Those are the kind of the backbone of therapy for ovarian cancer at some point, at least in the initial treatment. One of the big things, and Daniel's probably seen this with some of the patients going through the rehab program, is that unfortunately some of these drugs do have toxicity to our peripheral nerves. And so that can be really challenging for some people. Some people get chemotherapy and have no problems at all, or very transient feelings, changes in feeling in your hands or feet. But some people who are maybe older have other reasons to have changes in their peripheral nerves, such as diabetes or vascular disease or previous history of alcohol use or unknown. Can have a really profound, what we call a neuropathy or peripheral neuropathy, and that means changes in the sensory nerves. And we take everything in our health for granted until it affects your function. And initially, it's uncomfortable, and sometimes, and so this pain can be what we call neuropathic pain, and it can be more challenging to control because it doesn't respond to opioids or anti-inflammatories like other types of pain, like surgical pain. And it can often be worse at night when people are trying to get that restorative sleep, which is really classic of neuropathic pain. And then if it really does progress and we don't stop those medications or tailor them, or sometimes people have just kind of a very rapid onset of the neuropathy, it can affect function with people's ability to maintain their balance. And a lot of our patients are older with ovarian cancer, and that can be really challenging, especially at night where, people may not be using their vision for cues to go to the bathroom in the night. I'm always telling them, turn on the light, don't, because they have lost their balance, and, then you can have a secondary fall. People feel unsafe, and uncomfortable when they walk, and so that limits their ability to actually do some of the exercise that I often have people try to do, which walking, I think, is a really good exercise for people who feel the idea of exercise as a scary thought. And then it limits them, and it creates this terrible cycle for them. And then some people can't even, with their fingers, have difficulties, doing up buttons, writing. Those are other quality of life issues. So that's the big toxicity that a lot of women with ovarian cancer may see. And that can really affect people's ability to do activities of daily living, and certainly trying to push as they're starting to feel better, now they have something that's limiting them, and that can be really challenging.
Mm-hmm. And Daniel or Sarah, are there ways, though, that we can help patients that have unfortunately suffered that side effect in terms of improving their physical abilities? Are there certain exercise that you might focus less on and others that you would focus more on in a rehab setting, for example?
Yeah, and similar to Sarah's point regarding the individualization of chemotherapy to the patient, to the tumor, exercise is a behavior that's extremely individualized for a lot of different reasons that are unrelated to the tumor or the therapies. We can just think about our daily lives now. What barriers do we face to go for a walk? What barriers do we face to go to the gym or to be active in any particular way? Those are the same ones in addition to everything else that a person with cancer is going to have to face. So when we're talking about things like paresthesias or challenges holding different weights or different bands, for example, that we might use, or perhaps they have tingling or loss of sensation in their feet. These can create balance challenges, as Sarah highlighted, and our adaptation to the person to make sure that the exercise is safe is really the focus of exercise oncology at the practice level. So, for example, if a person was unsteady on their feet, well, then walking exercises may be ones that we are a little less likely to perform routinely. And we're going to start with seated exercises and build strength in the legs using other approaches, whether they're leg extensions or toe taps. And I think one of the things that Sarah mentioned really earlier on was that exercise is a lot of things. It's, like I said, not necessarily just killing yourself at the gym. For some people, exercise is deep breathing. And that really is the capacity they have because they are so exhausted. And we take it from deep breathing all the way to some of the highest intensity training interventions that we could think of that might be used for high performance athletes. And when you look at the literature, everything's been used. In plyometrics, which is typically an intervention that's used for jumping and high performance sport, is something that in fact has been applied in some research settings for people with cancer.
I really love that your idea about the tailored to, not just what the patient necessarily probably wants or is used to doing, but to what their functional ability and their goals are. Because I think that's probably will make it more sustainable as well.
Yeah, one of the things we talk about with patients is that, you may think of yourself as that 20-year-old version of a Olympic athlete or whatever high performance person you were in the past, but you've gone through quite a bit. And even though you have these, legacy thoughts about your fitness, you are the person you are the day that you need to start training. And sometimes that means taking it quite a number of steps back and starting at a place that seems like it's not very much exercise, like going for a short walk. And sometimes we often find that in and of itself is extremely fatiguing, but 5 minutes may be where we start. And then we work by the minute sometimes. 5 minutes progresses to 6, progresses to 7, progresses to 10. And on days where people are feeling particularly poor, we have to pull back. And on days where they're feeling particularly well, we try to advance them a bit further. But when we think about individualizing it, it's even if we try to provide a tailored exercise prescription for someone to do over some number of weeks, there's an oscillation on a day-to-day basis where people feel great on one day and poorly on another day. And it's not even at the daily basis. Sometimes it's across hours, as Alicia had highlighted. Mornings are better, afternoons are worse. And so there are lots of different angles to consider when we're trying to squeeze in a bit of exercise.
So we were discussing the challenges to trying to become more physically active and more fit during the course of treatment in women with ovarian cancer. We talked about peripheral neuropathy, which is damage to the nerves that provide us with sensation to the hands and the feet, as well as other functions. I I understand, Dr. Ferguson, that some women who have undergone surgery for ovarian cancer can also have significant swelling in the genital area, and that it can make it quite uncomfortable for them generally, but also to do exercise. Can you comment on what you've experienced, what you've noted in patients of yours that might have this?
Sorry about that, I was muted. So lymphedema, either the genitals or the legs, and it's usually a combination, but sometimes it can be more prominent in the genital region, so in the vulva. Both of those things related to usually surgery and having lymph nodes removed can be quite distressing to patients. So there's discomfort or pain associated with it just at baseline, depending on how swollen that area is. Mm. And it often gets worse with, standing or, being on your feet for a long time. But again, like many things, the more active you are, it actually helps with lower leg lymphedema because, Daniel can comment probably better than me, but the muscles do help with bringing fluid back, and lymph nodes, what they do is they bring fluid back to our blood system so it doesn't pool in dependent areas. And there's other ways to manage it with lymphatic massage and helping. Often the genital lymphedema is not in isolation, so it's often associated with upper thigh as well. It can be in isolation, but it's, I think, less common is what I see. And so there are ways that people wear compression garments that have to be measured, sometimes wrapping. It can get worse over time. So when people develop lymphedema, it doesn't happen right after surgery. It's usually something that happens with time. It's more a progressive late complication of surgery. But certainly if it's quite, I have patients who have significant either lower leg or genital lymphedema that at times it flares and it can really impede exercise. But again, I think this is where Daniel might want to comment on individualization and having a multi-pronged approach to dealing with it, because activity, though standing on your feet for 18 hours would make lymphedema worse, being active and having some kind of physical activity to use those muscles does help with it. I don't know, Daniel, if you want to.
Sure. In terms of lymphedema, there was a previous understanding that exercise would be contraindicated in those with lymphedema. And a lot of this was in the breast cancer literature with upper extremity lymphedema, where basically they said no exercises. But the literature has evolved, like much of it in exercise oncology and oncology in general, where exercise, in fact, isn't associated with an increased risk of lymphedema or an exacerbation of lymphedema, as long as it's tailored. There are very few instances of adverse events with respect to lymphedema due to exercise specifically. And even in the most recent guidelines describes that exercise is probably a good way to manage lymphedema. And as Sarah alluded to, the muscles, in fact, act as a pump to drive back lymphatic fluid into general circulation. That doesn't necessarily mean that we exercise without consideration for it. Certainly, when a person presents with lymphedema, there are strategies specifically to address that, and they include lymphatic drainage and specialists who perform different types of massage or compression or therapeutics that would resolve or work on lymphedema symptoms. It's not something that we would just disregard in exercise, without consideration. And if the lymphedema is severe enough, there very often is the incorporation of lymphatic specialists who participate in the overall care of someone with lymphedema.
So those specialists, not to go too off topic, but those specialists are trained in massaging the area to clear it of extra fluid and bring it up to the chest, where then it enters the circulation again. And
correct. And as a non-specialist in the space, I don't want to say too much, but certainly there are lymphatic massage therapists or lymphatic specialists. I won't necessarily just try to, I forget the actual term, but basically those who function to help support the drainage of lymph fluid from a given space.
Okay, good. So it's good to know that something can be done about this potential complication. And I'm sorry that I didn't ask this previously, but the peripheral neuropathy that perhaps even more patients might develop from the chemotherapy, is this something that can get better over time, Doctors Ferguson or Mina?
Yeah, with regards to the peripheral neuropathy, first of all, identifying it during therapy, really communicating with your healthcare professional about what the symptoms are like, the severity, how long it lasts is important, so they can modify medication and decrease the dose, and sometimes even stop the dose, because we don't want to leave someone with a permanent impairment. And generally, if it's mild to moderate, intermittent, like if it's not all the time, if it's not all the time, it gets better actually fairly quickly, and most people will have a complete resolution. But if it's persistent at the end of treatment, it will improve. And I tell patients up to even a year, there may be improvement. Okay. And not to get too discouraged about that. But if it's quite severe and quite painful at the end and persistent, it will improve. They may need help with medications. So I think a lot of the medications we use have side effects that are worse than the discomfort that they get. So I really, talk about that before we start, just empirically throwing some more medication at it. That time will help. And however, if it's very severe, they'll probably have something persistent, but hopefully not painful, just that they notice that, I feel like I walk on sand, but it's not painful. It's a little numb, but it's not painful. That's, not ideal, but it's better than living with the pain. So it does really better. And I see improvement even up to a year.
I just got a flashback as you were answering the question. So I finished chemo in April or May. I did have some damage to the peripheral nerves, but that was to be expected. And then I think it became off and on, as you described. And I remember one day my mother calling me and saying, "Do you want to go for a walk?" And I thought, oh, my feet are feeling kind of funny, but I'll go for the walk. And by the time she came over, I was on my bed, and I was really discouraged because the pain had become worse, and I didn't want to go for the walk, given the discomfort and that funny, disquieting feeling in my feet. And so that would have been in the early fall, I think. And I'm sure that within a few months of that time, I didn't have any symptoms anymore. Just to illustrate, your points about how it can present and what the timing might be.
And sometimes it even flares a bit after the stop of chemo, like you've seen them and you've seen your patient and they say, "No, it's okay, I have a little bit of numbness, not bad." And then you see them and then they're like, "Wow, it got worse." So sometimes and people have a little flare, a couple, like a month or two after, and then it gets better.
Yeah, it's interesting. Yeah.
Yes.
I mean, interesting, maybe from a very dry academic standpoint, but not for the patients themselves. No.
And just for patients who are watching this, who may be going through this, neuropathy, and I try to teach this to the residents and fellows, it's not just tingling. It can feel cold sensation, just feeling like my feet feel strange. It's a lot of different, it's not just pins and needles, which everyone thinks. So really describing the changes that you feel, whether it's just my feet are really cold every night, that is neuropathy. Like that people say it keeps me up, but my feet just feel cold.
Mm-hmm. So, okay. Well, thanks for that. That's why it's so good to have someone on the clinical side too, helping us with the podcast. If you guys feel we're ready to move on to a slightly different area, I wanted to discuss also the resources that are available to women who are going through this journey. I guess primarily focusing on the period after surgery, perhaps after the first couple or 3 cycles of chemotherapy.
Sure.
Mina?
I'll provide a couple of resources related to exercise and rehabilitation that are available to patients at the Princess Margaret and the University Health Network. But there are several others, and I'll touch briefly on those too. And I will put in a plug for the prehabilitation program at UHN, because we can receive referrals to those who are undergoing neoadjuvant chemotherapy prior to surgery. So within the chemo context, at UHN, the prehabilitation program can develop a very multimodal program to make sure that we're in as good shape as possible leading up to surgery. It includes exercise, diet, stress management, smoking cessation, if that's applicable, as well as other medical optimization features. Within the context of this post-operative rehabilitation, at the Princess Margaret, there's a fantastic program within the Department of Cancer Rehab and Survivorship called the Cancer Rehab and Exercise Program, abbreviated to CARE. And they have a very solid exercise and rehab program that is multi-professional as well. So physiotherapy, exercise professionals, including kinesiology, occupational therapists, psychologists, dietitian, extremely robust programming over several weeks of structured programs.
Great, thank you. And Sarah, do you have any comments that you'd like to make based on your years of following patients with ovarian cancer in terms of the resources available?
You know, one of the things is we're very lucky where we work to have this resource. It's certainly each cancer center may not have what we have at UHN and at Princess Margaret, but I have to say I refer many, many patients to the cancer rehab program. And it is really an extraordinary program. And they also help connect patients to their partners in the community so that they can continue on. So there are a lot of community partners with Wellspring, Gilda's Club, and others. And so I think each person, probably a lot of people in Ontario will be listening to this, and to talk to your cancer center and try to see what is available locally would be the best thing.
Great, good, thank you. Well,
And
I think
I'll just add one more thing
Sure.
to that comment, and that is, you know, patients can self-advocate for these services. And it very often, I think that sometimes patients, they go in to see their physician, they hear what their treatment plan is, they hear about the very tumor-oriented therapies, but
Yes.
they really can ask for supportive care services. And I think very often the physicians are extremely helpful in coordinating that care, but it may need to be put on their radar because they may not necessarily appreciate all of the functional limitations or stresses that treatment and the cancer are creating.
Yeah, thank you for mentioning that. I think it's really important. And it's an example of one of the pearls that listeners can pick up while watching or listening to the podcast. All right, so I think we can conclude the podcast. I certainly have received an education in exercise oncology. I've learned a lot from the both of you, and have been made aware of all of the very, very important research work that is being done in this area. And so I've thoroughly enjoyed it. And I'd like to thank you both, Dr. Daniel Santamina, with the Department of Kinesiology at University of Toronto, and Dr. Ferguson, one of our clinicians with the Gynecologic Oncology program at Princess Margaret, Director of Research in this area at UHN. I'd like to thank you both for participating, but also for doing the very important work that you do every day for many, many women affected by ovarian cancer. Thank you.